All right, so welcome everybody. Thank you so much for joining me here today to discuss the very timely introduction to the UK of Cyrex Array 14, which is a mucosal immunology screen. I'm Robin Puglia. I'm a certified functional medicine practitioner. I'm a clinical nutritionist, and I am the Cyrex Labs VP of Education for the UK, Europe and Ireland. Okay, so our immune system has two branches essentially. So we have the mucosal and the systemic immune system. They, of course, are united in the mission to protect the body against foreign antigens and foreign proteins. When the mucosal immune system and the circulatory or the systemic immune system are independent of each other, but they are in constant communication with each other. And the mechanisms through which they work are related but different at the same time as well. So the mucosal surfaces are home to 70% or more of the immune system, and the mucosal immune system acts as the primary host defense against physical environmental factors such as food, airborne molecules, viruses, and also commensal antigens that are living on our skin, in our lungs, in our nasorespiratory tract, and of course in the gut. And the mucosal immune system and the component parts of the mucosal immune system plays a really significant role of the barrier and the barrier surfaces of the skin, so the functions of the barrier surfaces of the skin. Mucosal immunity is the main functional defense mechanism in the urinary tract, the respiratory tract, and the gastrointestinal systems. And the mucosal surface interface is a really complex system that has to integrate interactions between the microbiome, the biofilms, the mucus layer, the associated protective compounds that are found on various different surfaces, such as defensins or enzymes, secretory IgA, secretory IgM, and all of the underlying immune cells in the skin, in the nasorespiratory tract, and in the lamina propria in the gut. So as I said, the mucosal immune system, and part of the reason that it's incredibly important this year and last year, I mean, in general, of course, but it is certainly on the main stage at the moment, is because it's the first line of defense when it comes to protecting our body against a variety of antigens as they're coming into contact with the human body. So these antigens, of course, are usually coming from the environment, or found in the oral cavity, inhaled into the lungs, or ingested into the gastrointestinal tract. So the mucosal system's major immunoglobulin is IgA, and IgA plays a really important role in elimination and management of food and bacterial antigens in the GI tract and also in the mouth. But in the mucosal immune system, we also have a secondary antibody, which is IgM, secretory IgM. And for any reason, if IgA becomes insufficient, then IgM can step in and actually compensate for the decrease in IgA function. So slightly differently than what happens in the systemic immune system, where IgM is the first responder, it's the big mama of the internal immune system. And then IgA comes up second if IgM isn't able to take care of whatever the antigen is. So we have in the mucosal immune system, IgM is supporting IgA, it plays a supportive role. So studies have shown that oxidative stress, parasitic infection, breast cancer, food sensitivity, gluten reactivity, celiac disease, and many others, I'll discuss this in a little bit more detail in a couple of slides, but all of these conditions are able to leave specific fingerprints in saliva. And that's because of the immune reactions that are occurring locally in the mucosal surfaces. Of course, saliva is it's the first secretory fluid that that is produced as part of the immune response in the mouth before anything even hits the lower parts of the gastrointestinal tract. So the major role of the IgA and the IgM antibodies that are produced in saliva is their binding capacity. So they bind to food and they bind to microbial antigens or to toxic chemicals that are found in the mouth, such as anything that's being leached from dental work. And they bind them in order to deactivate them, essentially. So they are supposed to prevent the entry into the submucosa and into the circulation. So they deactivate them, and in order that they can be eliminated before they create inflammation or damage the gut wall or damage any of the other delicate mucosal surfaces. And the act of the immunoglobulin binding to the foreign protein creates what we call the neoantigen. So that is an antigen immunoglobulin adduct, essentially. And the formation of these antigens, these new antigens, may actually contribute to the loss of oral tolerance. So if you have a lot of this particular immune reaction happening, then this creates enough of a drain on the immune system that inflammation is upregulated. You can end up with an inflammatory cascade as a result. And because this sort of becomes failure of that first line of defense or overwhelm of that first line of defense. So it's the first significant inflammatory challenge that happens before you start with intestinal permeability, before you start with other inflammatory reactions on the internal mucosal surfaces. So structurally in the gastrointestinal tract, the mucosal surface is made of this monolayer of epithelial cells, and there are 5 different types of epithelial cell that make up that gut wall. But on top of the epithelial cell, we have a specific immunological layer, which is made of your immunoglobulins. So again, specifically secretory IgA. But above that, we have this non-specific barrier, which is made of mucus, defensins, enzymes. And then above that, we have the gastric acid, the bacteria, and the dietary proteins. So this entire layer makes up a very, very important part of our immune barrier. And it is anything that happens in this primary surface has the ability to kind of make or break the inflammatory response as it then hits the epithelial layer. So in the epithelial layer, the antigen may have already, well, it has already encountered the defensins and the enzymes and the mucus itself, but also the secretory IgA. So understanding the health of these layers, I call it the immunological lasagna in my own clinical practice, understanding the health and the function of these layers actually really helps us to understand how our defense system is working, because if the secretory IgA component or the mucus component, the defensins and the enzymes are doing their job adequately, then by the time the antigen is actually exposed to the epithelial cells and the immune systems in the immune cells in the lamina propria, it can potentially already have been disabled or taken care of. And all that needs to happen then is that it's processed as technically a waste product. So when it comes to viruses, now viruses of course are a hot topic for obvious reasons, but the single most important factor which determines a virus's lifestyle once it has come into contact with the host is the constellation of the host's antiviral defenses. So the virus must protect itself against the antiviral mechanisms of the host, which includes that mucous membranes, the IgA and the IgM that are found before they even hit cell level. So the virus must first penetrate and persist through the defenses of the physical barriers, which I've just described, to encounter the innate immune system. And then it must fight through the defenses of the innate immune system in order to encounter the adaptive immune system. And it has to survive that process as well in order to replicate. So when it first gets into the body, the first line of defense are the acids, the enzymes, and the secretory IgA. And then we also have the phagocytes. So phagocytes, of course, break down the virus into small pieces in order that they can do antigen presentation. And the process of breaking it down, if it hasn't already been disabled by the mucous membrane, by the mucosal layer, the mucus layer, then phagocytes, of course, have the ability to break it down and disable it. So if your phagocyte process is working well and healthy and aggressively, then that can start to eliminate the virus as well. So phagocytes then start to present to T cells and the T helper cells, which communicate with B cells. We then start to produce antibodies, and the entire immune mechanism is underway. So viruses are not really alive. You know, they are pieces of RNA and DNA that are enclosed in a protective coating. They are, of course, parasites, and they have evolved to reproduce inside and survive outside the cells that they infect. So there are actually currently more than 50 pathogenic human viruses, although we don't really hear about very many of them. We tend to hear about, I would say, 10 or 15. And they are very, very small, but very, very efficient. So the hepatitis B virus, for example, has only 4 genes, but it is responsible for around 1 million deaths per year. So it is small, but very efficient. So there are 4 components of successful viral infection. So firstly, the virus actually has to infect the host cell or infect the host body in the first place. And there are 4 routes of viral transmission. We can inhale, we can ingest, there is vertical transmission, and then there is intimate physical contact. And of course, the thing that we are most exposed to is inhaled and ingested. We have really very few opportunities for vertical transmission, and intimate physical contact happens a lot less than inhalation and ingestion. So then the second phase, of course, is reproduction within the host cell. So they have to copy their genetic information and produce mRNA that will be translated into viral proteins. And then once that mechanism is underway, they have to start to evade the host defenses. And this needs to happen for long enough to infect either another host or to establish a latent and chronic infection or chronic infection. So reading about viruses is a lot like reading science fiction. Actually, for me, that was the experience, the feeling that I got when I started really delving into it. So the herpes virus family, for example, have more than 20 different mechanisms that they use to subvert the host immune system. And a lot of that has to do with changing the communication around antigen presentation. So that's just one viral family, have 20 different mechanisms for evasion of host defense down one pathway. So they're very, very intelligent for something that's not alive, and their ability and determination to succeed and to survive and to replicate is really very impressive and very significant. And then the final stage, of course, for a successful viral infection is continuing of transmission. So transmission to a new host, for example, via coughing or kissing. So of course, the transmission to new host, the most effective transmission to new host happens via inhalation or ingestion. It is via these mechanisms that it spreads most quickly and most easily through the community. And therefore, the mucosal surfaces that we're talking about and need to understand are the nasorespiratory surfaces and the gastrointestinal mucosal surfaces. So if you have healthy mucous membranes and you have cells that are making mucus properly, and you have good levels of mucus, and under that layer is a healthy level of IgA secretions, IgA is also found in other secretions in the body, such as tears, then we have a much more robust ability to protect ourselves against viruses and microbes and to defend ourselves once we're exposed. So the issue really is not so much, are you going to be exposed? It's what is your body going to do when you are exposed? Because it's all about the relationship. You know, human beings are designed to live in harmony, and to have, we have co-evolved in relationships with viruses and all different kinds of microbes. So the relationship between the virus and the immune system is the important thing, not the presence of the virus in the first place. So a collection of there is a very, very large collection of viruses that are found living in or on humans. And actually, the knowledge that we have around this, and in fact, the community of viruses that we have living on us, is constantly being updated. So the human virome comprises of eukaryotic and prokaryotic viruses, viruses that can cause acute, persistent or latent infection, and viruses that can actually integrate into the human genome, for example, endogenous retroviruses. The size of the human virome is not fully known. So our own cells are outnumbered by roughly 10-fold by the bacteria that live in the body. There are 10 times more bacteria than there are cells in the body, and that number might also have been underestimated. But it has been postulated that the number of viruses could be 10-fold higher still than the number of bacteria. So it has been estimated that there are over 380 trillion viruses inhabiting us. And if that doesn't slightly blow your mind, then I don't know what will, because that number is so huge that I can't really compute it properly. But again, it really brings me back to the point that we are designed to live in harmony with viruses, and understanding your immune system is the key to having a healthy relationship with the viruses that you encounter. So the other thing to understand about viruses is we are co-evolved with them. So the viruses and our virome are part of our immune system. They have the ability to modulate the immune system. And so the virome is considered to be a really important regulator of the intestinal homeostasis and also inflammation. The virome is able to stimulate continuous low-level immune responses without causing overt symptoms. And this is considered to be beneficial in somebody whose immune system is working functionally and who has a healthy relationship with their microbial ecology in general. So given what we know about virus and host interaction at the molecular level, it's actually a feasible summation that variations within the systemic and local gut virome act as commensal viruses. We have this relationship also with our bacteria. There is no reason to think that it wouldn't be the same with the viruses, and that viruses can even shape the immunophenotype of the host. So the relationship that you have with the viruses and the makeup of your virome can impact your immunophenotype and actually affect both positively or negatively your immune system, in simple terms. So again, quite interestingly, it is thought that some viruses can actually be protective against further viral infections and further bacterial infections. So if you have a healthy virome and a healthy viral relationship, then this can prevent you, in theory, from getting radically ill or suffering greatly if you come into contact with a more pathogenic virus. On the other hand, chronic viral infections such as those that occur with the herpes virus family or significant acute viral infections can have the ability of chronically suppressing the immune system, which makes you more susceptible to viral infection or infections in general. So from a functional medicine perspective, and at this stage in the pandemic as well, with new, more contagious mutations being discovered, it seems to me that the question is not if we will get infected, it's more when we will be exposed. So I personally think that this puts us as a community in an advantageous position of being able to prepare. So we know now that, of course, existing levels of inflammation and existing immune function will dramatically and drastically affect the outcomes in the face of infection. And we know the impact that immunonutrition, we know the impact that the gut microbiome, we know the impact that targeted nutraceuticals such as vitamin D, vitamin A, zinc, selenium, quercetin can make. in the face of infection. But what we have a little bit less information on is who requires what support, I think. So a comprehensive functional approach to an antiviral program involves not just a focus on the antiviral once you have the infection. Proactive intervention should involve identifying weaknesses in the immune system and working to correct those or to support those in order that prevention of infection or prevention of entry to the host cells is possible. So the more effective this strategy is, the lower the viral load will be. And of course, viral load is also associated with outcomes in the face of infection. So with adequate levels of mucus and healthy levels of IgA, then the virus will really struggle to attach to the receptor. And when this mechanism works adequately, then the infection may be completely stopped, even if somebody is exposed. So the best protection is that the virus cannot bind in the first place. So IgA is our first antibody. It's produced in the first 2 weeks of life. IgG is transferred from the mother and it protects the baby for the first 6 months, but IgA is the first antibody that our own body makes. And of course, that's because IgA is covering all of the mucous membranes and it starts to interact with the microbes on our immune surfaces at that very early immediate stage. So after 6 months, then we start to make IgG and IgM and eventually IgE. Okay, so I've included this study because I find it fascinating and relevant from a whole body, whole system, functional medicine perspective, but I hasten to add that this is really not the purpose of this webinar. But this small study, 73 hospitalized patients infected with COVID-19, tested positive for SARS-CoV-2 RNA in stool. So let me see. That was 53%. So 53% of this admittedly very tiny sample tested positive in stool, and the duration of the positive stool test results ranged from 1 to 12 days. However, interestingly, 23% of those patients continued to have positive results in stool that showed longer than the respiratory infection. So once the respiratory samples were coming back negative, stool samples were still positive. So again, it really brings me back to those mucosal surfaces and the importance of the gut and the gut immune system in any kind of viral infection, but specifically with what we're dealing with at the moment. So the next slide, I've just included a little bit more information if you wanted to read more about some of the presenting symptoms in that study. But then, of course, I'm delighted really to be finally talking about Array 14, which is the Mucosal Immune Reactivity Screen. So this is not a new panel, this is actually one of Cyrex's original panels, but it's new to the UK, and it really couldn't have come at a better time. So Array 14 is a saliva sample. It is not a blood draw. And of course, this makes it incredibly convenient to do if, for example, you're in lockdown and you can't access or go out and have your blood taken, and you want to be proactive about your health and understand your immune system. It's incredibly convenient for young children or for any of the multiple reasons that people can't have a blood draw or it's not possible at any time, but specifically now that that we're in lockdown and trying to reduce contact with the general population as much as possible. So Array 14, unlike most of Cyrex's other panels, is actually comprised of multiple antigens. So it's almost a snapshot of multiple different panels. So it covers a really wide range of markers that are related to the mucosal immune system, starting, but of course not limited to, secretory IgA. So inflammation and mucosal immunity is affected by a really wide variety of environmental and inflammatory factors. So stress is probably the primary and most immediate negative influence on secretory IgA in the mucosal immune system. And they've done studies using medical students actually that were that were doing exams, and they've taken samples before the exam, samples during the exam, and samples after the exam, and showed that during the exam, during that acute stress, or during that stress response, that activated stress response, that the secretory IgA was significantly suppressed. And then once the stress was over, once that stress response started to die down, that the immune responses recovered, which I found very interesting. And of course, that's also incredibly relevant because at the moment, as we are having such a big focus on taking care of our immune systems, and the importance of reinforcing our immune system is also a time when everybody, or the vast majority of people, are undergoing a really significant amount of stress between homeschooling children, concern about families, being sick, worrying about their health, not being able to get adequate food, all of the, being locked away for a year without normal social support is incredibly stressful for our entire community. Politics aside, like that's an entirely different level of stress. Just the stress of what we've undertaken in the entire year is incredibly relevant to the immune system. But there are other environmental factors as well, including gut dysbiosis, other infections, dietary protein reactions, chemical toxicity, and there are multiple different medical history risk factors as well that can have a really dysregulative effect on the mucosal immune system. So drinking alcohol is a really big one. And again, it was a bit of a joke every time we lock down that gin, sells out across all of the supermarkets. But every time I see that, my heart really sinks, because the reason that we're locking down is, because there is this really significant issue of viral infection. And one of 3 of the worst things that you can be doing for your immune system in the context of viral infection are drinking alcohol, not getting enough sleep, and feeling stressed. So given that this is our situation, and that the focus needs to be on really supporting the immune system, it's very, very important to understand which environmental factors are in fact influencing the immune system in the negative. So we don't really do a lot of tests in saliva. I do chronic viral or viral reactivation loads in saliva. We do some, stress hormone testing with saliva, but we don't really do a lot of immune system testing with saliva. So saliva is a mucosal body fluid that has really, really important functions from an immunological perspective in the oral, the gastrointestinal tract, nasal-respiratory tract, and general health. So the oral fluid that collects in the mouth and its contents of the parotid, submandibular, and sublingual glands, and of course hundreds of other minor salivary glands, and the gingival crevices help to clean the mouth, they help to digest food, and they help to fight tooth decay. So they are a very important part of the immune system in general. But they also carry many of the same proteins and other molecules that are found in blood and in urine. So from a proteomic perspective, there are more than 2,000 proteins and associated proteins in the human parotid and submandibular glands. So the saliva is actually a very protein-rich body fluid. So using saliva in a clinical setting offers many, many advantages, not only because it's non-invasive and also cost-effective, but also it's very accurate and provides quite a lot of value from a clinical perspective. So again, there are a lot of internal inflammatory processes that leave a really definite fingerprint in the saliva. So I've mentioned already gluten reactivity, celiac disease, parasitic infection, breast cancer, which of course we're not looking at with Cyrex, but oxidative stress, also inflammatory bowel disease, and lots of different types of infection are able to be identified in saliva. And because the mucosal surfaces are the first line of defense, elevated salivary antibodies involving the gut microbiome, gut-associated antigens, food antigens, xenobiotics, or anything to do with the enteric nervous system can be assessed in Array 14 and might be a very useful early warning sign, or even proper warning sign for inflammatory processes and inflammatory mechanisms that are occurring on the mucosal surfaces. So if this specific mucosal immune activity isn't addressed, if it's not identified and addressed, then we end up on the intestinal barrier, which can actually be damaged as a result of the continuation of the immune activation that first occurs in the saliva. So from a non-infection perspective, from an autoimmune perspective, what we see happening in the saliva is what happens first. So when you, if I use a different example, if I use a different analogy just as an example. So when we're talking about diabetes, we know that fasting glucose is one of the last markers to change. And actually fasting insulin and postprandial insulin is one of the first markers to change. So it's not something that we run every single time, but we know that it's the first marker to change and therefore is the earliest warning symptom. So by the time fasting glucose shows as being problematic on a test, you're actually already halfway down the pathway of metabolic dysfunction. So from an autoimmune perspective, this is the same. You'll see changes first in the saliva, and if you can pick them up in the saliva, then this is the earliest warning process available to us. So you can pick them up in the saliva often before they're starting to occur in the systemic circulation. So normal Cyrex panels are done with serum, they're a blood draw. So we're looking at the systemic immune system, which means it's already to a certain extent established. It has been established in the mucosal surfaces and then it has crossed over into the systemic immune system. So what we're seeing in saliva is that early warning. It's that the first marker to move, and therefore is incredibly valuable for early detection. And it's one of the reasons that this is such an incredibly important test to run on children, especially children who are first degree relatives of somebody with an established autoimmune disease, is because the earlier that we can identify an issue, the greater chance that we have of making clinically effective interventions that help to halt that process or potentially reverse that process, which from an autoimmune perspective is critical. So what do we look at in Array 14? So these are all of the markers, and you can see that Array 14 actually assesses multiple different antigens associated with the intestinal barrier. So we look at mucosal secretory IgA. So total secretory IgA, of course, is a biomarker for mucosal immunity. Low levels will indicate immune suppression and therefore the potential for decreased defense against infection. So this is really such an important panel to be running on anybody who is concerned about their ability to fight infection, especially infection that is going to be inhaled or ingested. Helping them to understand if they have an upregulation or a downregulation of that first line of defense is going to be incredibly useful for understanding interventions and how to really reinforce that system in order to have the best, most appropriate defense against infection. So high levels of secretory IgA in saliva indicate immune upregulation, which is of course an indication of inflammation. And one of the great things about Array 14 is that it doesn't just tell you the secretory IgA level, it's also looking at some of the reasons that that might be occurring. So some common foods that might be causing that, some infections or metals, to look to see if there's any clue as to why that's occurring, as opposed to just it's high or it's low. So this is what it looks like. So the ideal secretory IgA level is going to be, of course, within range. If you see equivocal or out of range, then this is mucosal upregulation, indicating, of course, an inflammatory response that's occurring on the mucosal surfaces. The immune system is fighting something. So this might be, of course, a healthy and appropriate response, but you need to understand why that's happening. So it allows you to understand it's happening so that you can investigate further what might be causing that, because, you know, we need to be always thinking about why is the immune system doing this? How can I support the immune system in doing what it needs to do? Is there an infection that needs to be cleared? Is there a food that needs to be removed? Why is the immune system upregulated? How can I support the body in this in doing what it's trying to do here. And then what this will look like if there is suppressed mucosal immunity is that you will see it below the range. And in this example, of course, we're just looking at secretory IgA. So when it's below the range, you'll have this little less than. So we look at total secretory IgA, but I will also show you an example of what it looks like when IgA is suppressed across the board. So I've included for you some factors that influence secretory IgA levels. So again, this will help you with your clinical decision making. So if secretory IgA is decreased, then you need to be thinking about why that might be occurring. And if it's increased, then you need to be thinking about and potentially investigating why that might be occurring. So this, I've provided you with this list, which is available in the Cyrex literature as well. And I will include a copy of the interpretation guide and the results table for you in the email that gets sent out with the recording of this webinar. But the point of this, of course, is that once you see that it's high or it's low, you're starting to look for reasons that might be. So that might require you to go back to the patient and be asking more questions and doing more investigation. If they don't have answers either from their medical history or from your conversations with them, then potentially you need to be considering something like dental infection or some kind of chronic infection that they might not be aware of. So secretory IgM, so due to the predominance of IgA secretions, most labs will actually generally only be looking at IgA. However, if IgA is suppressed, again, then IgM comes in as a backup. So in order that you get an accurate result as to what is contributing to this problem, Cyrex will actually test IgA and IgM simultaneously to all of the antigens tested. So if you are coming back as insufficient with IgA, IgM should still pick up what it is that's causing the problem. So if you're having an inflammatory response to something on the mucosal surface, you'll have an IgM positive. So it will still come up on the panel, and that of course provides you with the information that you need, as opposed to if we were just running IgA and IgA was insufficient, then everything would be coming back negative and you wouldn't have any answers as to why or potential clues as to what that might be. So in Array 14, there are multiple different gut barrier related markers. So we have gluten zonulin antibodies, actomyosin antibodies, ASCA and ANCA, which are autoimmune markers for the gut, calprotectin, and transglutaminase 2. So again, this is quite a comprehensive look at the gut barrier. Gluten zonulin, of course, are proteins specifically related to the tight junctions. Actomyosin antibodies are generally only upregulated in one of three scenarios: undiagnosed celiac disease, undiagnosed gut autoimmunity, or gut infection that is damaging the cell walls. So if you see actomyosin elevated, you know that you're not just dealing with garden variety leaky gut that a little bit of glutamine is going to help you with. You need to actually be investigating further to look at why that gut is so damaged. So ASCA, ANCA, and calprotectin are looking at inflammatory bowel disease, and transglutaminase 2, of course, is a marker for gluten-related enteropathy. Then we also have gluten-related biomarkers. So specifically, we're looking at native and deaminated 33-mer alpha-gliadin, and then we're looking at multiple different gluten and wheat proteins as well, including wheat germ agglutinin, gluteomorphin, which is one of the neurological breakdown products of gluten, and we're looking at transglutaminase 2. So that's not, again, it's just a marker that features, I'm mentioning it twice because of course it is potentially gluten related as well as being gut barrier related. I can see that some of you are asking questions, but because I'm alone on this webinar and I don't have any of the Regenera support staff with me today, I'm going to do all of the questions at the end. So thank you so much for interacting with me, and I'm sorry that I'm not acknowledging that mid-webinar, but I will do all of that at the end. So positive results here can indicate early reaction, early identification of gluten-reactive gluten reactivity. And again, this makes it a really valuable tool for children and people who suspect that they might be reacting to food but aren't currently able to go and actually have a proper blood draw. This also helps you with identification of inflammatory reactions to foods which might be having a massive impact on the immune system, and that kind of inflammatory challenge will affect somebody's immune defense against infection if they were to get any kind of viral infection. So as well as gluten markers, they're also looking for antibodies against egg, soy, corn, alpha and beta casein, casomorphin, and aflatoxin. So multiple reactivity in this area. If the panel comes back positive for gluten, egg, soy, corn, casein, then potentially what you're looking at is a real problem in your oral tolerance mechanisms. However, if just one or two come up positive, then that's really an indication that you've got some food reactivity. Array14 also looks at the chemical family. So aflatoxin, of course, is a chemical as well as being food related. BPA, mercury, and mixed heavy metals. So this, of course, BPA, mercury, and heavy metals themselves are too small to create an antibody. So when you have antibodies coming back positive on one of the Cyrex panels, including Array14, it isn't actually an antibody to BPA. It isn't an antibody to mercury. It is an antibody to BPA bound to the protein of the person who has done the test. So it is bound to albumin, meaning that the BPA or the mercury or the mixed heavy metals are attached to the tissue of the person who has taken the test. And now that has created this neoantigen, which I've talked about before, where you've got this immune complex of the antibody to the tissue bound to the chemical, that is no longer recognizable to the immune system as being self. So that albumin doesn't look like albumin to the immune system anymore. It looks like a foreign protein. So at that point, you make antibodies to that neoantigen. And that's what we're measuring. So it is a significantly bigger red flag than just identification of BPA, because it means the BPA is attaching to tissue, and that tissue is no longer being tolerated by the immune system, and that is creating enough of a response that the immune system is now creating an inflammatory action against that neoantigen in that tissue. And then there are as well pathogen-associated markers. So we see markers to LPS and also antibodies to rotavirus found in, so IgA and IgM antibodies to LPS and rotavirus. And of course, LPS, understanding whether or not you have inflammatory reaction to LPS helps you understand if there is a gram-negative infection or gram-negative dysbiosis occurring in the mouth, the nasal-respiratory tract potentially, or of course on the gut wall. But because LPS is so significantly inflammatory, it helps you really understand whether or not there is a really profound challenge happening to the immune system. And then there are also enteric nervous system markers. So there are myelin basic protein and blood-brain barrier proteins. But it's important to note not to confuse these with serum testing. So when we see blood-brain barrier protein or myelin basic protein in antibodies in saliva, these are very specific to the enteric nervous system and are not an indication of neurological autoimmunity elsewhere in the body. And there is also the final marker on Array14 is immune complexes. So immune complexes are the immunoglobulin and the antigen bound together, and they have the capacity, IgA immune complexes specifically, have the capacity to transport intact peptides across the epithelium using specific receptors. So the way that it works is this, and this can be beneficial or detrimental. So in the case of Shigella infection, IgA above the gut epithelia, so IgA binds to the Shigella and transports it whole across the gut wall, where the internal immune system, so the M cell, remember earlier I said that there are 5 different kinds of epithelial cell. So this cell here is an enterocyte, but this cell here is an M cell, which is a more specific immune cell than the enterocytes. But is also part of the gut epithelia. So it's one of the cells that makes up that single cell barrier of the gut wall. So the IgA transports it directly through via a receptor on the apical membrane of the M cell here. Transports it whole. If it was transported under normal circumstances, it would be broken down. Or if it wasn't bound to the IgA, then the Shigella has the ability to massively damage the enterocytes or the cell, the cells of the gut wall. So by binding it with the IgA and creating this neoantigen, this immune complex, sorry, not neoantigen, by creating this immune complex, the IgA is protecting the gut wall against damage from the Shigella, and it's protecting the gut from permeability or cellular damage. On the other hand, when this mechanism happens with gluten or with gliadin, and so under normal circumstances, gliadin is broken down by enzymes either in the lumen or inside the cell itself. But when it's complexed with gliadin, then it hits the receptor CD71 and it is transported whole, so intact, into the systemic circulation. So you see here that without the IgA binding, it is broken down via enzymes and degraded into smaller amino acids or peptides. When it's transported intact, in fact, what happens is upregulation of the immune response. And in the case of celiac disease, where this mechanism is really upregulated, where you have a lot of CD71 on that cell membrane, and transport of gliadin directly through the cell wall intact, then you have a massive inflammatory reaction and autoimmune response that occurs. But because this mechanism occurs, because because IgA is in saliva, and because this immune reaction is capable of happening in saliva on contact, I also want you to think very carefully around what that means for somebody that has gluten-reactive autoimmunity or food reactivity when they come into contact with that. They don't have to swallow the product in order to create an inflammatory reaction. When I was first diagnosed 16 years ago, one of the things that I used to do when I was really desperate for a piece of bread was I would put it in my mouth and chew it and then spit it out. I was very young, don't judge me. Thinking that because I didn't swallow it, that was okay. So I'm not, of course, suggesting that any of your patients are doing that, but think about the products that you're recommending to them, and the language that you're using around degradation of gluten, because the reaction happens early and it happens in saliva. So by the time that a digestive enzyme, for example, has come into contact with the gliadin, the immune response has already been activated. So you might be reducing the total load of gluten and breaking it down, but you're not preventing that immune response. You're not protecting the body from that immune response. You're just reducing the total burden that occurs. So, practitioner to practitioner, I want you to be aware of that. So that is all of the markers that is found on Array 14. There is a full interpretation guide and the interpretation tables that I've mentioned, and they're found here. So when you log into the Cyrex website, they're found here inside the education library. However, I will be including the full interpretation guide and the interpretation table PDFs with the handouts and the video recording of this webinar. So here is what some of the results look like. So I mentioned to you that I would show you what it looked like when somebody was immunosuppressed. So And this is what you'll see. So all of the markers are negative, but nothing in normal range. So this person, I would say, has IgA insufficiency and also IgM potentially insufficiency. So this is probably a person who is either on immunosuppressive medications or has an immunodeficiency of some kind. And you can see that all of those markers are all below the reference range. Actually, except transglutaminase. So this is a significant problem. This person is very, very susceptible to infection and of course requires a significant amount of support. So this person is at significant risk for airborne pathogens such as respiratory viruses, colds and flus. This person, however, is polyreactive. So this this I see more and more in my clinical practice as I'm dealing with more and more complex cases where we don't have just a couple of obvious markers. Everything is lighting up like a Christmas tree across the board. However, when you see this in salivary reactions, remember that the secretory IgA is going into overdrive, potentially secretory IgM as well as the backup if there is any fatigue from the secretory IgA. What is happening here is that the body is working in overdrive to protect the systemic immune system. So this is potentially the first stage of immune defense against something that is causing significant irritation or significant perturbation to the mucosal immune system. So you might see this and not see gluten reactivity necessarily, or not see something occurring yet in the systemic immune system. So this potentially is a protective mechanism, but when you see that, what you need to then be thinking about is, where is this coming from? So this is very likely to be either a chemical exposure, a significant food reactivity such as gluten or dairy, or some other really significant personal reaction, or an infection. So this person might be dealing with a chronic viral infection, an Epstein-Barr reactivation. They might also have some kind of dental inflammation going on that's creating this really significant upregulation of inflammatory responses on the mucosal surfaces. So this is both a positive and a negative result. So generally, I think that you should be encouraged when you see this result, because the immune system is doing exactly what it needs to do. It is doing its best to protect and defend the barriers and the surfaces. And then your job becomes finding out what is causing that massive amount of activity and that massive kind of influx of protective activity. Okay, so this is a normal, healthy person. This is what it should look like. So no reactions and everything except for gluten in range. So I'm not concerned if there is one antibody that is below the range. Everything else looks normal and healthy. And this is ideally what you want to be working with for somebody at this moment in time. This is what we're aiming for. And then you see, I'm going to just run you through some quick other examples of what you might see in clinical practice. So here we see lipopolysaccharides, IgA and IgM positive, but you don't see any gluten reactivity, and you don't actually see any markers for gut permeability here. So this makes me think that you might be dealing with a dental infection potentially, and it's not involving the gut, or possibly a nasorespiratory infection as well. So definitely requires some kind of investigation, definitely requires some kind of immune supports, but you're not necessarily thinking gluten reactivity, significant gut involvement or gut damage. Here we see lipopolysaccharides and transglutaminase 2. So now we start to see that this is showing some immune reactivity on the gut wall. So transglutaminase 2, of course, involves the gut epithelium. So this now looks like it might be more local to the gut, whereas the first one that didn't have any gut markers whatsoever, I'm actually more thinking that it's not involving the gut, but one of the other mucosal surfaces. Here we have something that is much more pronounced, looking at so transglutaminase 2, alpha and beta casein, and we also have some chemical immune reactivity here. So we've got chemical loss of tolerance, some early activation of food reactivity, and some gut damage there. So I'm, in this instance, potentially thinking about the mouth again, asking questions around whether or not there is any history of significant dental work or significant exposure to heavy metals in other places, because it looks to me like there is inflammation on the gut wall, some food reactivity, and potentially some loss of oral tolerance, which might be secondary to loss of chemical tolerance. This kind of reaction is probably what you will see more commonly. This, where you see a few positive, a few equivocal, and so this and this is the most likely to be the most common scenarios that you'll see in your clinical practice. So here we see that there are multiple markers all the way across the board. So we've got total secretory IgA elevated, we've got lipopolysaccharides elevated, occludin zonulin indicating that there is some intestinal permeability, we've got some reactivity around foods, so alpha gliadin, wheat germ agglutinin, so some gluten reactivity there, some wheat reactivity, we've got transglutaminase 2, so we're seeing inflammation on the gut wall. And we're seeing some chemical immune reactivity as well, and we're seeing some enteric nervous system dysfunction. So this is a gut that's pretty inflamed, and it's an immune system that's pretty reactive. So this is not something that really indicates end-stage autoimmunity, but you're seeing early significant immune disruption on the barrier surfaces across multiple different antigen profiles. And so that really brings me to the end of my presentation. So Array 14, of course, is non-invasive. It assesses mucosal reactions to a broad array. So it provides you with a really good snapshot of what is going on and potentially what is problematic to the immune system, which is incredibly helpful from a clinical perspective. It identifies early events, measuring immune reactivity at its earliest stage. So it's our earliest ability to detect a problem, which is brilliant. It looks at gut dysbiosis, which of course is very important for inhaled viral infections as well. It helps to monitor effectiveness to the dietary protocols, and it is cost effective because it effectively assesses multiple antigens at once. So you're combining markers from all of the different profiles, and it's the only way that Cyrex really does that, where you're looking at the enteric nervous system, food reactivity, intestinal permeability, and total immunoglobulins as well. So it's a really, really brilliant comprehensive panel. So in summary, humans are infected by many viruses every day. The most important variable is in the context of host virus outcomes is the host's immune system. The mucosal surfaces are the first line of defense and engagement in new viral infection. So accurate assessment of the mucosal immune system allows us to be proactive and to create appropriate interventions and to support this really critical system. The best vaccine is enhancement of your immune system, irrespective of where you lie in the actual vaccine debate. So the mucosal immune system and cell-mediated immunity, such as phagocytosis and natural killer cells, are an important part of antiviral immune defense. And understanding where the weakness lies really helps us to be practical and guided in our interventions, as opposed to just making general immune strategies, which may or may not be required or effective. So that is the end of my presentation today. Thank you all very much. And I'm going to now look to see what questions you've got for me. So there's quite a few. So if the client has nicotine gum regularly, would it still be worth doing the test? I would say yes, because you absolutely want to see what effect that nicotine gum is having on the immune system. You do the test first thing in the morning. before, so given 12 hours, preferably as long as you possibly can away from the nicotine gum. Let the mucosal immune system recover and let all of the salivary secretions come up overnight, and then do the saliva sample very first thing in the morning before they have any more gum for that day. Ideally, if you could get them to stop for 48 hours before, that would be even better. Would you say that the current strategies to remove chemicals and heavy metals, such as chelation binders, sauna, etc., are able to deal with the tissue-bound biotoxin or the new antigens? If not, what strategy is available? The issue there is not so much body burden. So strategies to remove chemicals, such as supporting the body's own elimination of ability to eliminate. So supporting phase 1, supporting phase 2, supporting the gut and elimination. So infrared is elimination through the skin, is reducing the total burden. But when you have that neoantigen and it is bound to tissue, we're not talking about body burden, we're talking about loss of immune tolerance to that chemical. So reducing the amount of the chemical is going to help, because it reduces the amount of target for the immune response, but it doesn't actually change the immune response. You actually need to work with calming down the immune system and working on it becomes an immune system issue, not a body burden issue. And you need to be very, very careful when there is chemical immune reactivity with anything along the lines of chelation. So when you are transporting the toxin around, you are creating more opportunity for that to bind to tissue. So you need to work on the immune system significantly first before you start doing anything very aggressive. I would say working on the gut, working to support the liver, and natural forms of elimination and infrared sauna are probably the safest. I wouldn't really do any other kind of detoxification while there is still chemical immune reactivity. Do the foods need to be in the diet for the markers to show up, and if so, for how long? Yes, you need to be eating the food in order to be making antibodies to the food. And the general guidelines are you need to be eating the food for at least a week. An antibody life cycle is 25 to 50 days. So we generally recommend eating the foods every day for 1 week and then running the test at about day 28 if day 1 of eating the foods is day 1. So for normal functioning small intestinal mucosa and good fat metabolism and avoiding steatorrhea, are there any markers on this test that might be identified? I'm sorry, I don't understand that question. For normal functioning small intestinal mucosa and good fat metabolism, avoiding steatorrhea. The normal functioning small intestinal mucosa, we're looking at occludin zonulin and actomyosin, and the total secretory IgA. There isn't anything on the test that looks at steatorrhea or fat metabolism. Is that true for all autoimmune conditions? Sophie, I'm sorry, could you tell me which part is true for all autoimmune conditions? Given the numbers of new mothers who won't have antibodies to pass on to their babies due to the increased vaccination program, which does not confer lifelong immunity, we have to assume that most babies won't be protected by mother's milk during the breastfeeding period unless the mother has actually had the childhood disease herself. Can I comment? Okay, so you're talking about specific IgA to specific infection. So if the mother has had, for example, chickenpox, then they will have an IgA to chickenpox, IgG to chickenpox, and that will confer benefit, protection against chickenpox to the infant. I think that's where you're going with that. But because of the vaccination program, that IgG won't necessarily be present, and therefore the infant isn't protected. True. That is true. And also, as long as the mother is breastfeeding and the baby's getting colostrum and the mother is eating a whole foods diet and the mother has worked with a practitioner to identify any inflammatory food issues, if the baby was born vaginally, the baby was breastfed, or support has been done, there's been swabbing and probiotics and all of the normal things that we would do to support an infant and the development of the immune system in the infant, potentially including supplementation of colostrum or vitamin D earlier on. Anything that we can do to support the development of that child's immune system is going to be helpful in the developing the child's own defense against infection. So one of the most important parts of defense against infection is exposure. So if this is of concern in the individual, because of course we are always only working with an individual or potentially a family, then my advice would be to get that child as dirty as possible. Make sure that that child isn't growing up in a really sterile environment and allow them as much exposure to the immune system, although not to chemicals, but to dirt and to potential pathogens as possible in order to prime the immune system. Okay, are there any issues in terms of shipping saliva samples to Cyrex? So I have had to recently stop all sample shipping to Europe because of Brexit export and import charges. So yes, this saliva panel at the moment is really only available in the UK. It won't be available in Europe while we're still experiencing problems with Brexit. And because it's saliva, although I might have to check on that and get back with you, but to the best of my knowledge that is true right now. There is also this sample has to be shipped within 24 hours, so it doesn't have, with serum samples we've got a much broader window to get it back to Cyrex. So for example, payment needs to be made at the time of ordering for this, because there isn't any wiggle room for making a payment and delaying the Cyrex won't process samples if payment hasn't been made. So there isn't any wiggle room for waiting for payment to be made in order for this sample to be processed. So it's currently only from the UK, shipping directly to the States, and there is definitely an issue with time frame there. So if everything goes to plan, then it isn't a problem, but payment needs to be made at time of order, and there can't be any issues around shipping to Europe at the moment. How much is the test? That is a very good question. I don't know off the top of my head, and I should definitely have checked that before I did the webinar, because I should have known that somebody would ask, but I will definitely include that in the email that goes out. Is this test useful for somebody suffering long-tail COVID? I would say definitely yes, especially in the context of understanding if there is anything that is bothering the immune system. So long-tail COVID, of course, there are multiple issues around long-tail COVID. In my own clinical experience, one of those issues is that COVID layers on top of existing issues, and those existing issues might have been existing below the surface. So like that iceberg sitting below the surface, and COVID has just pushed everything up above the surface. But because COVID was the trigger, the straw that broke the camel's back, there hasn't been much identification of or emphasis on the pre-existing immune and inflammatory issues or burden of the body before COVID happened. So definitely this will be useful, especially if the person is really bedbound or struggling to get out of the house, to understand what's going on with the immune system, to look at what's going on in the gut, to look to see if there's potentially some gluten reactivity, some dairy reactivity, their IgA responses, lipopolysaccharides. Very, very important for neurological inflammation, which is one of the hallmarks of that kind of persistent fatigue, if that's one of the symptoms of COVID, that the long COVID that the person is experiencing. So I would definitely say yes, especially if they're struggling to leave the house. Okay. So Array 14 can be done on children. I would recommend from the age of 3 onwards. but could also potentially be done if you wanted to look at wheat or dairy reactivity before that. Can I explain more about why secretory IgA could be either raised or decreased in celiac disease or in inflammatory bowel disease? So secretory IgA, because it is the first inflammatory defense on the gut wall, when you've got an inflammatory issue in the gut, secretory IgA is essentially working overtime. So one of the factors around celiac disease in general is that you can end up with IgA insufficiency or deficiency. Where other immunoglobulins have to provide backup services because IgA gets really depleted because it's been essentially working overtime for years or even decades. So in the initial inflammatory responses, then IgA should be high as it's working to protect the gut, working to protect against antigens, working to disable antigens because there is a massive inflammatory challenge in that mucosal surface on the gut wall. But over time, then IgA can become depleted or decreased. So it slightly depends on where you are in the immune challenge, and that's not always going to be true for everybody. So for some people, IgA will be high all the way to diagnosis, but for other people, they can become depleted quite quickly. There is some genetic predisposition to that, or just other influences depending on what other immune triggers they have in place. Can this panel replace Array 3 now that we can't get to phlebotomists during lockdown? So it's not going to replace Array 3 completely, but it is absolutely very, very useful to use while we can't use Array 3. So 150% I agree with that statement. It's really brilliant for, it doesn't do the full Array 3. But it's looking at enough markers, and especially that it includes native and deaminated gliadin, which I think is a really important marker to be checking on everybody that we can. So yes, it is a really, really good replacement for Array 3 and also Array 4, looking at the casomorphins and the alpha and beta casein to look for dairy reactivity, plus corn and some of those other markers, corn and egg. And actually brilliantly, it's kind of 3 and 4 in one place. So it's not the whole panel, but it's enough that it really provides you with a good understanding of tolerance to foods. So do you need to be eating a certain amount of these foods for the results to be valid? So the way that I normally explain this is that what we're trying to identify is if there is something in this person's diet, or if there is something in this person's lifestyle or environment that is contributing to their symptoms. So if they're not eating a food, then that food is not going to be contributing to their current ongoing symptoms. If they're eating a food enough to create immune system disturbance, and they've been doing that for a long time, so even if they're only eating wheat once or twice a week and they're not eating it every day, if that's their normal eating pattern, that is going to show up on a test. We're trying to assess what they're actually doing in the context of their real life to see what it's how much it's contributing to their immune system dysregulation. So if they have removed a food because they thought it was causing trouble, but they don't really know, it's at that point that we kind of want to challenge. If they're only eating it every now and then, once every 3 or 4 months or less, then that food is unlikely to be a major contributing factor to their ongoing health issues. If someone is on immunosuppressive meds, is it worth doing this test? I would say probably not, but context matters. So if they've been taking methotrexate and steroids for 4 years, then they are potentially going to be immunosuppressed enough that this test would come up negative. But if it has come up completely negative, you can also run a total immunoglobulin panel. Although, mind you, that requires a blood draw, so you can't do that with Array 14 now that I've said that. So possibly not, but context matters, it depends. Does the test look at natural killer cells? No, this test doesn't look at natural killer cells. would it be advised to wait some time after having amalgam fillings removed before testing? So actually, I would probably do it before doing the amalgam filling removal to see if there's immune reactivity to the mercury, if that's possible, to help really support them properly while they're going through amalgam removal. Otherwise, I would probably do it within 2 to 4 weeks of having those amalgams out, because again, you're not looking at body burden. It's not going to show you how much mercury is floating around in the system. It's going to show you if there is an immune system problem with that mercury, and you need to know that sooner rather than later. Can we access CD57 from the test? No, CD57, which is a natural killer cell, is not on this test. So if a client has not been eating eggs and grains for a long time, it wouldn't register these foods as potential problems. That wouldn't be a false negative, that would be a true negative, because there are no antibodies, and but that's because they're not eating the food. So if you were to reintroduce the food, then you would have an accurate test result. So would I suggest this test for somebody recovering from COVID? Yes, I would. All right, so that is all of my, that's all the questions. If anybody has any final questions for me, now is your opportunity. But if not, thank you all, everybody, for joining me. Thank you for asking excellent questions. And I look forward to seeing you all at our next webinar. And I will be sending out the, invitation to the Q&A with Dr. Vojdani, where you can ask him all of your most pointed and urgent infection and immune system questions direct to the master himself. Thank you again, everybody, for joining me tonight, and have a lovely evening and have a lovely week.